are the active range of motion, airplane movements. It's the general screen to check for active range of motion limitations. And it's done bilaterally, if possible. Okay? So we've got shoulder flexion, external rotation at the shoulder. We've got shoulder extension and shoulder internal rotation. Okay? Then we've got full shoulder abduction. Okay? And then we've got horizontal adduction, and they were already in abduction, so horizontal adduction. Okay? Elbow extension. Okay? You can do pronation supination next, wrist extension, wrist flexion, and then open and close the fingers. Okay, so if they can't do full on one side or for one movement, that's when you know, okay, I need to spot check that a little bit further because there may be an issue there. Okay? So let's say it was shoulder flexion and my right arm only went to here. So that's when I would say, can you go any further? And then if you see this, you know they're compensating. If they say, nope, that's as high as I can go, then that's a cue to you that there either may be weakness, okay, if they can't go against gravity any higher, there could be some kind of arthritis or some kind of a joint issue, okay? So that's when you know you need to go ahead and make sure that you proceed with passive range of motion to that joint, in that joint area. You would not write within functional limits on that, and you would test further. And if you are able to get it up, moving it passively for that client, and they don't have pain, and they, you can go all the way up, then that's a sign of weakness. Okay? If you can also only get it to that part, then there's some kind of restriction of some kind, whether it's capsular, whether it's soft tissue, it could be arthritis, and so forth. So that's again a key that you need to take further steps to understand what's going on there. So we have the universal goniometer here with the stationary arm and the movable arm and then the axis. Okay? And the first movement that we're going to be demonstrating is shoulder flexion with scapular elevation, or what we typically refer to as just shoulder flexion, full shoulder flexion. Okay? So, Kathy, you just put your arm down at your side for us, all the way down the side. Thank you. What you want to make sure that you're looking for here is the acromion process. Okay? And that is your landmark here, and you're putting the axis right up against that. Okay? And you've got your stationary arm pointed perpendicular to the floor in a seated position. Okay? And I'm going to go ahead and ask you to go ahead and raise your arm up as high as you can. Okay? And is that as far back as you can go? Okay. So the stationary arm in this case is midline to the lateral aspect of the spine, parallel to that. And then the movable arm is parallel to the longitudinal bone of the humerus. Okay? So there, the reading I get is 162. Okay, so now we're going to do shoulder extension. And so again, it's the same sort of start position as with shoulder flexion. You're finding the acromion and you're putting the axis of the goniometer there. The stationary arm is going to stay down perpendicular to the floor, and she is going to bring her arm posterior into extension as far as she can. Okay, so I'm making sure the stationary arm is in midline with the lateral aspect of her trunk, and this one is along the, again, longitudinal aspect of the humerus. And can you go any further? Good. Okay. All right, that's good. Come back down. And so again, my reading is from 0 to, looks like 67, 68. Okay. So with shoulder abduction through elevation or shoulder abduction, what you're going to want to do is you're going to want to find the coracoid process, okay, and then you come down just below that. So kind of put your thumb on it and then roll down, and that's where the axis goes, okay. And the stationary arm is parallel to the midline of the trunk. Okay, you do need to be careful that if their spine, if they have a scoliosis or are leaning one way or the other, that you're trying to line it up with midline of the trunk. Okay, so just watch the spine, sometimes is tricky. Okay, so patient, what I would like you to do is to go ahead and bring this arm all the way up towards your ear, as high as you can. Okay, so I'm bringing the goniometer up here, and again, the movable arm is parallel to the midline of the humerus, as best as you can. Double checking this, and that is about 181. So now we're going to go into external shoulder rotation and internal shoulder rotation. So let's just demonstrate those movements in sitting. Kelly, if you can keep your elbow here and flex your elbow to 90 like this, and if you can come out towards me and then go in towards your belly. That is sole internal and external rotation of the shoulder. Okay? Alright, so let's come to neutral. Keep your elbow at 90. Okay, and so for this one, because of the nature of the movement, the axis, it's a rotational movement, so the axis is right at the base of the olecranon, with the stationary arm going straight out from the patient. And let's go external rotation first, so come out towards me. And I'm watching to see that there's no scapular retraction or anything that would give her other compensatory movements. So double check the stationary arm, and the movable arm is parallel to the long bone here. Okay, and go ahead and relax. And so that movement was 0 to 73. So for shoulder internal rotation in this position, the limitation automatically is she can only go so far to her belly. Okay? But if someone can do that, then that should be noted as within normal limits or within functional limits. Okay? So we will do the formal measurement. So go ahead and come in towards your belly. Okay, and I'm double checking the alignment of the stationary arm. The movable arm is parallel to the long bone. Okay, and relax. And so that movement was from 0 to right at 65. So I'm going to have her start here and come back as far as you can for shoulder
can you name the
abduction, and come forward across as far as you can, shoulder adduction. Okay, so start position is out here. Okay, the the axis point is again the acromion. That will dip right there. Okay, the stationary arm is perpendicular to the line of the sternum, or coming out to the side. And the movable arm, let's see, come back first. Let's do horizontal abduction. Come back as far as you can. Okay, is that good? Is that as far as you can go? There you go. All right. All right. And relax. And so that started at 0 and went to 65. All the way across as best you can. Okay, and if I felt like I needed to assist, this is a better position for me as the therapist coming across this way than trying to grab in here. Okay, so if that's good, I'm double checking here. The stationary arm is again along the humeral longitudinal area. Okay, and relax. And that reading was from 0 to right at 140. Okay, so we're going to go into elbow movements next, and elbow extension / hyperextension is the first one that we're going to start with. So Kelly is just going to leave her arm straight down and straighten it as most as she can. Okay, and relax. Okay, and so from here, and what I noted when she did was a little bit of external rotation. So you do need to watch for that. So we want you to keep this part of your arm straight and just straighten your elbow as much as you can. Perfect. So we are going to use the lateral aspect of the epicondyle for the axis. It is in an open position to test for extension. And the stationary arm is along the humerus, parallel to the longitudinal bone of the humerus, and the movable arm is parallel to the long bone of the radius. Okay, so is that as straight as you can go? Okay, so she has just a little bit of hyperextension. Let me show you that. Just relax for a second. So we started at 0 and she went to like 4. Okay, or you can look down here. So we would start at -4 hyperextension. Okay, find the condyle again. Okay, and now this time we're going to go ahead and have you come up into elbow flexion. Okay, and again we're looking parallel to the lateral aspect of the radius here. Okay, this one's good, and just relax. Okay, and so that one we started here, okay, at 180 and went all the way up to 30, okay, which is 150. Okay, because you're looking at where the movable arm moved from. So you can actually go this way to 150, okay, or look from here to here and subtract. It's the same thing. Okay? All right. So we're going to move on to pronation and supination, and I'm just going to have our subject here demonstrate pronation and supination. So pronation and supination. And again, with this one, you want to watch that they're not doing any substitution. You want to make sure that the elbow is firmly planted at the side. And actually, what I would do is actually have her maybe hold her humerus here. I'm going to ask you to go ahead and grasp this pen sort of right in your thumb and sort of hold it upright like this. Okay, so that's where we're starting. You're going to come right here to the third metacarpal with the axis, and you're going to line up the stationary arm perpendicular to the floor, and the movable axis should be straight up and down. So you're trying to make sure that they're starting in that position. And let's go ahead and have you do pronation first. So tilt the pencil as far down as you can. And we're looking parallel. Make sure you get a good angle there. This is perpendicular to the floor. This is parallel to the pen. So that line should match that line. Okay? And so the reading there would be from 0 to maybe 75, 80. Okay? And then we'll go ahead and go right into supination. Come the other way. Good. Okay, I'm going to reposition that. And I'm going to come so that the movable arm is parallel to that. Okay. And that was about 105 because we started at 0 and she went down to there. So that's 105. So we're going to do wrist flexion and extension, and in order to best position your client, you're going to have them with their forearm supported on a table with their wrist hanging off. And we're going to go into wrist extension first, and she's going to start in neutral. Go ahead and demonstrate wrist extension. There we go. And wrist flexion, good. And so starting out in neutral, and you're going to take the axis and put it right below the ulnar styloid, and keep the stationary arm parallel to the longitudinal aspect of the radius in the ulna, and then start here with the alignment of the 5th metacarpal, and go ahead and pull your wrist up for me. Good. And then the movable arm is parallel to the long bone longitudinal aspect of the 5th metacarpal. And I slid there a little bit on the stationary arm, so that looks about parallel to me. And so we started at 0 and came up to about 65, maybe 64, because this one was just a hair shy of 65. Flexion, which is the same starting position as wrist extension. Okay, and just bring your wrist down as best you can. Good. And again, you're looking to make sure that you're parallel with the long bone of the 5th metacarpal. Okay, so starting at 0, and we went to about 83. Okay, so now we're going to go into MCP flexion of the digits, and IP flexion, and then DIP flexion. And so what we're going to do here is we're going to take the half dial goniometer along the back side of the 1st metacarpal, okay, and along the movable arm goes along the back side of the 1st interphalangeal, 1st phalange. That's open. Put your thumb up.
Oh,
yeah,
sorry.
so it's not in your way. So then go ahead and bend that as far as you can. Okay, and so that's about as close as she can get. And that is right at 90. And so you would use that same technique for each of the metacarpals for 2nd through 5th. And then we'll go into IP flexion, okay, is going to be along the long bone and then along the phalange there. So as far as you can go. So this one can go a little further, okay, and it's actually right on that middle part, okay. And so that one is about 66, and then for the PIP, sometimes what you have to do is, especially with a goniometer like this, I'm not going to be able to get a good reading all the way in her palm. Okay, so for this one, I'm going to go ahead and allow her to bend here, and then to go ahead and try to curl as much as she can at her, with trying to keep the rest of her hand out of the way. So we're right along the back, the stationary arm's right along the back of her digit, and then you're coming down along the last. Let's see, yeah, see, we're going to go ahead and extend your wrist just a hair. That's why I recommended in class that maybe you cut the goniometer, okay? But that's, I mean, she can't go any further, so that would also be within normal limits or within functional limits, okay? But the movement there, okay, looked like it was about 96. So for extension of the hand, true function is if they can just open their fingers all the way. Other than that, you're really looking at almost hyperextension of the fingers, and unless you're in a hand therapy center, taking the time to, if they have full extension and can flatten out their hand, to get the measurement here is very specialized. So I don't think we need to spend time on that. obviously if they can't get here, okay, then you're measuring the amount of extension. Okay, so let's just pretend you have a limitation at your MCPs. Okay, so she's got a limitation of coming out into full extension. You're measuring it the same way as you would joint flexion. Okay, and that would be a limitation. I want to make sure I'm reading it right. Yeah, that would be a limitation of full would be 0, and so that would be a limitation of 60 degrees. So as far as thumb goes, the thumb is significant with occupational therapy because it is what gives us our grasp, our functional grasp. So the main one that I would like you all to know is the movement of opposition. Okay, and so the way you would test that is to see if they can touch their thumb to their pinky finger. Okay, and sometimes it is where you know if they can't touch all the way here, you're checking to see if they can actually get to one of their other fingers. But true opposition is coming across to the little finger. Okay, if they can't get all the way there, then what you are probably going to want to do is measure from the middle of the pad of the thumb to the middle of the pad as close as they can get. So just from skin to skin. So that would be about 2 centimeters away. And then you're going to try to work to see if you can't close that.